All right. Thanks everyone for joining us. I'm Roger Woods, Director of the Brain Mapping Center. It's my great pleasure to introduce to you today our special speaker, Professor Mark Haacke. He's the director of MR Research at Wayne State University and Vice Chair of Biomedical Engineering there. Also has appointments at Loma Linda and Case Western. He's a past president of the International Society of Magnetic Resonance Imaging and Medicine in 1994, has received a gold medal award from that body in 2004, as well as comparable awards from the Society of Magnetic Resonance and the International Society of Neurovascular Disease. For anyone clinical in the audience, you probably are familiar with Dr. Haacke's work in susceptibility weighted imaging, which he pioneered and has led additionally to quantitative susceptibility mapping as a spinoff of that, or further developments of that. He's also very well known for his work in fetal and placenta imaging, for those of you interested in development. And on the research side, he's really done a lot of important work in terms of that's very pragmatic in terms of standardizing protocols. And he's going to talk to us today about a technique called STAGE that is very important from the standpoint of being able to do very comparable imaging on many different scanners at many different sites. And then secondarily, he's going to talk with neuromelanin, which I know is of great interest to a lot of our research community, playing a role both in movement disorders and sleep disorders, in depression and anxiety, just to name a few. So I will let him get started. Please welcome Dr. Mark Haacke.
Well, thank you very much, Roger. It's really a pleasure to be back here again. It's been about 15 years, I think, since I gave a presentation here. In those days, I used to do traumatic brain injury. And so there was a big group here that was involved in that. And that's what brought me out here. So I'm also here because you all have a great interest in movement disorders and Parkinson's disease. And we have tried to apply this standardized imaging specifically to that area. So let me start here. The method we use is called STAGE. It's a data acquisition technique, and we also have special processing that goes with it. It stands for Strategically Acquired Gradient Echo Imaging. And there are a number of other multimodal methods out there today referred to as fingerprinting and multiplex and callus and probably many others that are developed locally at different universities. But of course, it's hard to really get something like this adopted internationally. And so we have tried to collaborate with sites around the world with this. We have about 20 sites in China using it, and a number of sites in Europe and here in the US and in Canada. So why do we want to look at rapid standardized imaging? Well, first, the normal methods that people use clinically are T1 weighted images, which are really very nice today at 3 Tesla, and T2 weighted images and SWI. And the problem is that these take on the order of 10 minutes to acquire that data. And many clinical protocols are much longer than this. Perhaps in the US, they scanned a patient every 30 minutes, even every 45 minutes. In China, where I do most of my research on this project, every 8 minutes. So they have to scan people very quickly. And this is the type of result that they get, which is not too bad. So why standardized imaging? Well, first, using 3D gradient echo imaging, we can improve image quality and create uniform images. That means we can correct for RF coil effects. We can correct for what we call B1 receive, which is based on the type of coil. We can correct for B1 transmit, which is a physics problem on how the radiation penetrates into your body. We can create a standardized imaging protocol that takes between 8 and 10 minutes, depending on the resolution you're interested in. We can obtain a number of quantitative biomarkers, such as water content, T1, T2 star, susceptibility. And then, of course, because there are so many different types of images you can create, once you know the tissue properties, you now have a choice of what images you want to see, which means one protocol basically can fit all. Some people call that the one-stop shopping center, but actually that's getting very close to being true. And then one of the exciting things is that if we can get enough sites using this, that we can have standardized data for future AI uses. So you could imagine if you scan somebody here for Parkinson's and then they move to New York and you scan them again a year later there to follow up, you'll get the same answer you got here. And I think this is very exciting and really makes it possible for AI to play a big role in brain health. So we collect two 3D gradient echo scans. One we use with a low flip angle. And unfortunately, my mouse does not show on your screen here, but on the left-hand side, this is the original images, and you can see the coil effects. And after we do the correction for this by calculating those field effects, we get a nice uniform image. And then the 30-degree original image is seen here a little bit bright on the bottom right side, now nice and uniform for the 30 degrees. So, oh, okay, will that do it? Laser. Wonderful. Okay, great. Thank you. Okay, so we've also developed a new method for optimizing T1 contrast, which we're quite excited about. So the corrected image is on the left-hand side, but the optimized T1 weighted scan is on the right-hand side. And you can see a significant improvement in signal to noise. This is not even using the AI methods that are available on the scanners today. So everything I'm showing you here is without any AI noise reduction techniques or super resolution techniques. So you can only imagine that in the future, these are going to get better and better as time goes on. So I'm showing you an example here of sagittal acquisition. Again, with the original bias data, you can see the cerebellum is very bright here because of the coil effects. Corrected, it becomes uniform, and then optimized, you can see the T1, excellent T1 contrast. So now for those of you who have some radiology background or MR background, this is a little quiz. What am I? What are these images? So as a technologist, you probably know the answer to that question. Axial. Well, they're axial. No. What type of contrast does this represent? T2 weighted contrast. Well, good try. The one on the left is the T1 map. And you have to realize that the water content, the one on the right is water content drives T1 and T2. So the higher the water content, the longer the T1, the longer the T2. And that's why the spin echo looks like this. But I actually don't need T2 anymore because this image looks like this image. The difference is this is fully quantitative. So that's a huge advantage. Here I can tell you what the water content is. So CSF is 100%, white matter 70%, gray matter is about 82%. So all of this you have directly from these images. So how are we collecting this data? Well, we can do this very quickly if we run a short TR. So here's an example. If we run a TR of say 27 milliseconds, we can collect 5 echoes. We can get a long TE, so you can get a good SWI out of it. The total scan time is 2.5 minutes for each flip angle, so 5 minutes. So all the different contrasts I'm going to show you are all obtained from that 5-minute acquisition. If we don't really go to the long echo times and we just live with 3 echoes out to 13 milliseconds, the total scan time for both acquisitions is only 3 minutes and 12 seconds. So you can see it's really quite amazing the information we got. So if you needed to scan a patient quickly and you didn't have time for anything else, FLAIR or spin echo, anything, you could be done in 3 minutes. So really tremendous possibilities here. So here's an example of a clinical acquisition where we actually do 0.67 by 1 millimeter squared in plane resolution and 2 millimeter thick slice. That 2 millimeter allows us to collect the data that fast that I just showed you. If we want to do a better job, now I'm going to take 3 minutes to scan instead. I'm going to have 1.34 millimeter thick slices. The in-plane resolution is identical. The signal to noise here is worse because I have higher resolution as usual. what's the difference if I reformat these? And this is the advantage of 3D, right? If I reformat these, this looks a bit blurry with 2 millimeters. Well, it depends on your clinical use for it. If it's just to see where you are or where the tumor is, then you probably don't care. If you really want to be looking at something like hippocampus or pituitary, then you want the higher resolution, and you have much better gray matter, white matter boundary. And so you take an extra minute to acquire the data. It really depends on your clinical use. So these are some results, possibly even me. I was just scanned in Detroit a week ago using this protocol. And here you can see the data is acquired in the transverse mode. And then I just blew this up. This is the reformatted sagittal mode. You can really see gorgeous contrast here. It reminds you of MP2 RAGE, for example, but MP2 RAGE takes a long time to acquire and only gives you T1 weighting and the T1 map. Whereas this sequence gives you all the different contrasts that we've talked about. It gives you SWI, it gives you what we call double inversion recovery to look for small white matter lesions. It gives you a T2-like image showing you the loss of signal in the high iron content. It gives you a QSM image, and it gives you a spin density image. So all of these come together from that scan. So we took this into the clinical world at 2 hospitals in China, and they run a 4-minute clinical protocol followed by DWI and FLAIR. So the total protocol is about 7 to 8 minutes. And these are the images that they acquire with 5 millimeter thick slices, which I think is terrible. I mean, that's what people have been running for 40 years. Why the heck are we not using modern technology here? You can also see, even though these are supposedly corrected on the scanner, which is the Prisma, by the way, it hasn't really done a good job. So you might say we correct the corrections, and this is our T1 weighted scan, and this is the simulated T2, and here's the reformat into the sagittal mode. And that's really what they want clinically. However, for free comes the T1 map, comes the SWI, comes QSM, comes R2 star maps. So all of this just comes naturally to complement that. So we've started to look at a broad variety of clinical applications. You can see here the list on this page. I'll show you an example or two about tumors and stroke and MS in the next few slides. So this was one of our first scans run at Zhongda Hospital in Nanjing in China, I think on a VIDA scanner. We got the R2 star map, we got the QSM. This was the T2. The T2 showed nothing. The diagnosis of this patient was there was nothing they could find. And here's the SWI. And if you look really closely, you can actually see eye of the tiger here. So this is actually a pecan case. If you measure the iron content here, it's 3 times higher than normal globus pallidus iron content. So a clear indication of an NBIA example. So why do we want quantitative imaging? Well, of course, the normal T2 does a great job in detecting tumors. This is the SWI of a tumor. It shows possibly blood here. Here's a T2 weighted. Here's the R2 star map showing possibly blood, and then the T1 weighted. So is it blood? Well, by using QSM, you can see that the iron content shows as bright and the diamagnetic calcium content shows as dark. So in fact, this is not bleeding or iron inside the tumor. It's calcification, meaning this may be an oligodendroglioma. This is another example from Shanghai, 4th hospital, though, specifically designed for stroke. So here we ran this with very high resolution, 0.67 by 1. It's a 4-minute scan specifically designed to be able to map out the blood vessels and give you an MRA-like result. And then luckily they acquired it with a second flip angle. And so here's the MTT map from the perfusion weighted imaging. Here's the original 5-degree data, and you can immediately see on the longer echo these what we call asymmetrically prominent cortical veins. This is an indication of reduced blood flow, increased deoxyhemoglobin, and is usually a sign that the tissue is still functioning because it's still extracting oxygen from the blood vessels. So if we go now and look at the spirit process results, here's the R2 star map, and you can see here, not only can you see these very clearly because of the increased susceptibility of high deoxyhemoglobin. You can also see a blush effect here. That blush effect may be corresponding to an increased CBV in that area. Here on the SWI, you can see the asymmetrically prominent cortical veins are very clear, indicating you basically have the whole hemisphere that is being affected by reduced blood flow. And on the right here, you have the QSM, again showing the dramatically increased susceptibility that has occurred on the stroke side. So we hope that this, for stroke, could become a very important application of this technology. Again, why qMRI? Well, here's an example on a T1 weighted image where you have, on the same person, you have a dark spot here in the putamen, a dark spot in the globus pallidus. What are they? Well, on a FLAIR image, if everything is dark, it could be water content, or it could be iron content, because FLAIR is using a TE of about 80 milliseconds. So what is it? Well, the FLAIR shows bright here, and if we go to the R2 star map, it shows dark, and of course, R2 star is 1 over T2 star, right? So high T2 star is low R2 star, which means lots of water. So this is just water. And here, if you look at the QSM in the globus pallidus, this is mineralization. You have very high susceptibility in this case. So you can now tell the difference between those two. Another very interesting application that we've just published a paper on is using the quantification of water content to study white matter hyperintensities in multiple sclerosis. And sometimes you will see the lesions are much brighter than in some lesions than others, but sometimes you get this hole in the middle, and this makes it look like what's called a ring lesion, but it's not a ring lesion. In fact, the only reason that it's dark here is because it's got higher water content, and FLAIR suppresses higher water content. So again, you have two possible sources for suppressing that, right? One is high water content, one is high iron content. What is it? It's high water content. And it turns out that these also correspond to what they call black holes on the T1 weighted images for multiple sclerosis, but it's really caused by high water content. So normally, the relapsing remitting lesions are about 80% water content. These particular lesions are around 90% water content. And of course, if you hit 100%, it means you've lost all tissue. So this is a way to map locally chronic lesions, water content increases, and potentially looking at tissue atrophy within the lesions themselves. So it's a whole new ballgame for studying MS. Just to demonstrate that to you more clearly, here's an example of FLAIR showing a dark hole in the middle. Here's the proton density map. It's obviously lots of water. And if you do a plot of the signal for FLAIR as a function of water content, you can see that the signal, that's why we use FLAIR, right? But the lesions get brighter and brighter and brighter up to about 80% water content. But of course, look what happens after you go past 80% water content. You now begin losing contrast. And this just shows you how the T1 intensity is directly related to the water content. So it's good to have a quantitative understanding of what you're looking at. Well, here's an example of double inversion recovery, which I really like because it suppresses CSF and white matter. So here's a FLAIR image that suppressed CSF. And you can see 3 lesions here, but you see them much more clearly on the double inversion recovery. It used to take 8 minutes a scan for double inversion recovery, then 4 minutes. And that's from just one double inversion. There are 3 different double inversion recoveries. It takes 0 seconds to do this because we have all the tissue properties. We've just predicted. We don't need to acquire that data. So what are the new contrasts I've really introduced to you here? The double inversion recovery is one, the T1 map is one, the R2 star map is one, and QSM is one. So these are things that clinicians basically haven't had available to them that become available if they need it. Otherwise, if they just want those T1 and T2 images, they've got them in a rapid 3 to 5 minutes, depending on what they want to look at. So, of course, there's a lot of processing involved in doing things transverse. The images are actually much more well-behaved and much more beautiful when they're collected sagittally. There's some good physics reasons for that. But here I just show you a sagittal acquisition, which is 0.67 by 1 by 1. Takes a little more than 3 minutes. Depending on the coverage, can be 3.5 minutes. You can see the white matter boundary of the hippocampus very well. Here's just another slice, and here's the pituitary. So you can see the infundibulum clearly in the pituitary because you're doing such high resolution. You're not doing it over 4 millimeters. This is an example just sent to me by Junyoung Bai in Seoul National University in Korea. This is a sagittal data set she collected. Here's the original data. Here's our spirit process data over 1 millimeter, and here's the same data over 2 millimeters. And you can see that the image quality is significantly improved. But what I want to show you is this. If we're looking for microadenomas inside the pituitary, you want to run this with high resolution. So here you can see a small microadenoma inside the pituitary with 1 millimeter thick slice, but it's starting to go away already with 2 millimeters. If you had run it with 3 millimeters, you probably would not have seen it. Now, this is not with a contrast agent yet. So, of course, this would even be more interesting if you ran this pre and post contrast. In that case, you would only need to run the low flip angle, high flip angle pre, followed by 1 high flip angle post, because that's where you're going to get the enhanced T1 effect from the contrast agent. And then you can do many different calculations. You can actually get a fantastic MRA out of this if you have pre and post contrast. Many pieces of information become available if you do that with a contrast agent. And this is another case that she had sent just to show you, again, the image quality with this high resolution sagittal imaging. And then this is the reformat of the sagittal into transverse if you really want to look at it that way. So if I had my choice, I would have sites in the US run this sagittally, because the US doesn't care if they take 4 minutes for the scan or 7 minutes for their scan, because they're already taking so long. And in this case, it would eliminate many of the other scans they do anyways. So, that's the one thing I like here. We'll take the time to do a good job. So this would be my recommendation for standard clinical scanning. One of the doctors, Liu Yu in Shanghai, has also been working with me on a clinical stage protocol. We've done about, I think, 500 cases almost, where we've compared the clinical protocol with this stage protocol. And this is a breakup of all the different type of patients who are here. So most of them hypertension and metastases. And you can see that this is the number of microbleeds listed. But since we don't use gradient echo in standard clinical imaging, you don't find any of them. And so here, if you look at these, you also find cavernous angiomas, hemosiderin, iron overload, developmental venous anomalies. All these things become clear with SWI. So basically, their work says that you need SWI for every brain scan. So basically, SWI reveals something new in about 1/3 of the patients. If I throw away those people who have just a single microbleed, then that's 67 out of 227 cases where we find multiple microbleeds, we find CAA, we find subarachnoid hemorrhage. So anyone who is not doing this is missing it. Now, I can tell you that I was at Loma Linda a month or two ago. They run SWI on every brain scan. But of course, they have to run this with an extra scan. That's okay, because today used to take 4 minutes for SWI. Now with the rapid imaging, I think Siemens on the Prisma can do this with Capriana, Wave Capriana in 2 minutes. So it's not really a big deal. But I think the take home is you should be doing it. And this is an example now of the next stage of what we're trying to propose is, well, why take 5 minutes to acquire all that data? Why not do it in that 3 minutes and 12 seconds instead? Well, then people are going to complain. It's not a long enough echo time. It's not TE20. It won't show you all the veins like you're used to seeing on SWI. It doesn't matter. What's most important are the abnormalities, not do I see pretty veins. Now, this is funny for me to say this because I invented this, right? And I loved those early artistic results. But now I'm saying, well, wait, let's look at these. Do we detect all those microbleeds if I only use T 13 milliseconds? So remember, I had 5 echoes. So I just threw away the last 2 echoes and when reevaluated the data with just the first 3 echoes. And you can see, you see it fine. It's, not maybe to the same detail, but do you find it? Yes. Here's an example where you can see a little bit more detail in the longer echo. but is it basically the same clinical interpretation? Yes. Oh my. Well, what does that mean? That has huge implications. It means you don't need to run long TRs and long TEs to do SWI on everybody. If you're just using it to look for significant clinical abnormalities, you can run it with this very fast mode. So it's really amazing. Now we're talking, 3.5 minutes for a standard clinical scan. Run a 1-minute DWI, you're at 4.5 minutes, run a 2.5-minute FLAIR. So you get some spin echo associated with this, and you're a 7-minute protocol. Okay, next patient, please. And that could dramatically change the throughput in American sites and European sites. This was just to show that when we evaluated the microbleeds with the 3 echoes instead of 5, we basically got identical results. So we're just preparing a radiology paper on this right now. Hopefully, the neurologist will pay attention to this. So I'm going to shift to Parkinson's disease and what we call the Parkinson's Disease Imaging Consortium, PDIC. I also call the protocol that we're going to talk about, which is the stage plus MTC stage, I call that the PDIC protocol, because we're using this on all movement disorder cases. So people are studying movement disorder with looking at volumetrics, looking at free water and DTI, looking at functional imaging changes. We've been focusing more on iron content in neuromelanin, although we're just starting to use volumetrics now as well. So when we're looking at the midbrain, the key element here is the substantia nigra. And here you have the red nucleus. You have 2 parts to the substantia nigra. The SNPR is in yellow, the SNPC is in blue, and the SNPC is the one that has the neuromelanin that we can visualize with MR. So here's an example of trying to see what's called the N1 sign. This is a susceptibility map. This is the original magnitude. This is what's called true SWI. And you can see this loop here. People called it the swallowtail originally, but there's actually a loop associated with this. You only see that if you do this with high enough resolution and focus on the iron effect. This is the same concept run on a cadaver brain. It's 50 micron in plane resolution. This one took 10 hours to collect. This one took 5 minutes to collect. So can we really do this practically? Yes, of course we can. The problem with the N1 sign is very complicated. There are at least 10 different manifestations of the N1 sign. So, to do a clear job on this, you really need a high resolution protocol. Here's an example of a 70-year-old healthy control, which would indicate that the N1 sign is very clear for you. Usually if you have the N1 sign, you're not going to have Parkinson's. And I'm happy to tell you, I love tennis and badminton, and this is my images. So I have a good N1 sign. This is really great news for me. And here's an older Parkinson's patient. You can see it's completely gone. That territory is now all filled with iron. So basically what has happened is the neuromelanin has depigmented, and the neuromelanin is an iron chelator. It's a metal chelator. And so it's dumped that iron back into the tissue, and now you can't find that N1 sign. So when we see something like this, Parkinson's, not ET, not something else, Parkinson's. Now, one of the most important things is really to look at the neuromelanin. So we can also map out neuromelanin from the cranial here down to the caudal portion. And you can see that this really follows the image I showed you of the substantia nigra pars compacta. In the caudal region, the neuromelanin completely matches the SN. If you now look at the Parkinson's case, we've got about a 50% loss of the neuromelanin. And that supposedly from some very early work from the 1980s, it's been shown by cadaver brains that you have 50 to 60% loss of neuromelanin before the subject starts to show physical effects. And that's, we don't get quite that loss, but we do see some patients with that loss. Now, the other thing we do is we like to take the T1 weighted images, which often cannot see the SN, the STN, or the globus pallidus. So if you're using free surfer or something else and you have T1 MPRH, you won't find those. So you really need QSM. And you can see in QSM, everything shows all those deep gray matter structures. they show very clearly. You can see the red nucleus clearly, the SN clearly. So of course, we combine both of these together. And there are a number of sites out there today that are creating AI programs that will automatically use QSM and T1 and then fully segment the deep gray matter. Now, what's really important in my mind is to overlay the neuromelanin on top of the QSM results. So the blue represents the QSM results with the high iron content. The red represents neuromelanin. And you see what happens here? This looks exactly like that cartoon I showed you at the beginning on the healthy control. And you see caudally, the neuromelanin completely overlaps with the SNPC. And look at what happens in the case of the Parkinson's. You can see about half of that. So indeed, that individual is about 50% of neuromelanin. If you make a plot here of neuromelanin volume versus SN volume, you can reasonably well separate Parkinson's from healthy controls. Now, does that mean you can separate Parkinson's from MSA or ET or something? Maybe not. There you really need to include more information, I believe, like volumetrics. But I'll show you something interesting in a minute. So we published a paper on this, I don't know, maybe 2 years ago, showing all the N1 sign in all these different movement disorders, from RBD to the different types of PIGD and TD for Parkinson's, PSP, MSA, and ET. And the ones that really tend to show the loss of the N1 sign are the PIGD. They have significant atrophy of the SN and significant loss of neuromelanin. So I'm going to show you another study that we've been looking at here, putting together a combination of the high resolution stage versus lower resolution stage, a total of over 500 Parkinson's cases and over 200 healthy controls. These were scanned on either a Prisma or Siemens scanner. One of them had the higher resolution here, which is on the order of 1 cubic millimeter, whereas this one is on the order of 2 cubic millimeters. Does it really make a difference? Because this scan is much faster than this scan, almost half the scan time. So first, what we wanted to do is to get an estimate of what are the errors involved here. So we did an interesting plot. We plotted the left side and right side for each structure. So we looked at the volumes of left and right, assuming that for most of us, those volumes are equal. And so you can regress out the line associated with this, and you can then immediately get an estimate for the error of the methodology. That error includes both the extraction of the deep gray matter, it includes quantifying the volume, it includes the errors in the MR system itself. So all these errors together, they all turn out to be somewhere around the 10% level. Maybe worse for the STN because it's hard to really localize the STN. So this gives us an idea what type of error exists for each individual. If we look at the low resolution versus high resolution, the low resolution has lower AUC as might be expected. The high resolution has a higher AUC, maybe peaking to around 0.85. When we include all of iron, SN volume, and neuromelanin volume and neuromelanin contrast. And although 0.85 is good, I would like to see this at 0.95 or higher. So how are we going to do that? We really need to incorporate new information. And I think the volumetrics will help with that. And that's something you can do, obviously, with the images I've showed you here. You can take those T1 images and do volumetrics with it. Maybe adding the DTI free water would make that even stronger. I know David Valancourt is really a proponent of the free water as a key biomarker. So I just wanted to give you a visualization as, for how the neuromelanin changes from healthy controls to Parkinson's. And actually, there's really a large standard deviation here. So if you look at this just from the standard deviation of each histogram, it doesn't look like there's really a huge difference. But you have to remember each bin has about 50 people. Square root of 50 is 7. So you have to divide this standard deviation that you see here by 7. And so that's going to change this to about 10 units. So the p-value here is very small if you look at it as a distribution. If you want to say, can I tell for one individual case that he's always different from healthy control? The answer is no. However, you can tell if they fall in the lower part of this distribution, it's going to be much clearer to say they're Parkinson's. So when you have a very negative result, very high probability that it's Parkinson's. If it's kind of intermediate, it may be hard to say that's the case. So I just wanted to show you the real data here, and that, you know, sometimes people, I think, exaggerate a little bit, saying, "Oh, look, I can separate these populations." They can, but can they really do it for individuals? Maybe not. So we also had another little theory here, and this is quite interesting, that PIGD patients are generally worse off than tremor dominant. And you have to remember something else, which leads to this hypothesis, that essential tremor, I can't see any difference between healthy controls and essential tremor. They don't show the loss of the N1 sign and neuromelanin. So they're a different beast. Maybe they have some things going on in the dentate nucleus, for example. And PIGD, on the other hand, they really don't do well. So I made the hypothesis, what if we go and separate out PIGD from TD? Will we see any differences? And lo and behold, you can see we do. You can see that the PIGD has lower neuromelanin, for example. If we go and look at, sorry, that's very blurry for some reason. If we go and look at some of the volumetrics associated with this, again, you can see more loss of volume in PIGD in some of the structures like globus pallidus. So this is very interesting. Now we're getting to the point of potentially subcharacterizing within the PD population itself. So I think there's still a long way to go, but a lot of possibilities for continuing to enhance our biomarkers. Okay, so now that brings us to the LC. I know you've all waited a long time to get to this point. So this is kind of a cute picture here. This was from our paper, which made the front cover of Neuroimage. I called it the red-eyed bamboo tree frog sign, or for simplicity, the frog eyes sign. And simply because it has these really nice bright regions, and then it has this boundary, which really reminded me of this frog. So that's a really good sign. If you see that, you know you're doing the measurement well. The problem with the LC is it's extremely tiny. It's like one of these bands of the paper clip here. It's barely 2 millimeters across. It's 12 to 17 millimeters in length. We rarely see it that long. We see it mostly on the order of 12 millimeters long. But of course, it's very important, and there's many groups interested in this. So, you know, is it associated with rapid eye movement or REM sleep behavior? Is it associated with wakefulness, higher cognitive functions, memory and consolidation, pain modulation? All of these things may have implications for many different diseases. So I want to show you now something where we have taken the same stage sequence and simply clicked on a button called MTC on. So that basically turns on the MTC pulse. It will increase your TR by maybe 5 to 7 milliseconds, depending on how high the effective flip angle is. In Siemens' case, I believe the pulse is 10 milliseconds long with a 500-degree flip angle and a 1200 hertz offset. That's how they do their MTC. So we run this with, I show 3 different flip angles here. With a really low flip angle, you can actually see that the LC has very high water content. Basically, it looks like gray matter. It is gray matter. At 18 degrees, we can see the frog eye sign. And at 30 degrees on me, you can see still some result. And I was just mentioning to Roger that on young people, sometimes I don't see this very well at the 30 degrees, especially on the Siemens with their MTC sequence. And that could be that they have higher water content than I do. And the higher the water content, remember, the longer the T1, and therefore the more you suppress it with high flip angle. So we might see some variation with age like that that doesn't indicate there's anything wrong. It's just a slight change of tissue properties. And this is the coverage that we do here with 48 slices. So it's 2 millimeters thick. And I wanted to point out to you, by collecting here just above the corpus callosum and just below the cerebellum, you can also use this same sequence to do iron content measurements. So you can use it to get R2 star, you can use it to get QSM. So in principle, if you don't really want a high resolution structural image, you could do this in one 4.5-minute scan. So if you had the signal to noise, so this is a 4 minutes and 21 seconds. So potentially you can do it fast, and the faster the better, because you're also imaging patients, right? So here's the actual data I showed you, but using the same processing that we did before. If I take the 8-degree and 30-degree, which is how we collected most of our data in China. So we collected low flip angle, high flip angle, and then we can reproduce any flip angle we want. So by doing that, I can create the 18-degree. So even if I didn't see it on the 30-degree, and even if I can't see it well on the 8-degree because the CSF is so bright, it kind of blocks and blurs over the LC. And there's my simulated result. So you can see they're pretty much identical. Is this what we would expect? Well, if we put in the tissue properties of the LC, its T2 star value, its T1 value. Its T1 value is much less than the conventional cortical gray matter, and even less than things like the thalamus, for example, and putamen. That short T1 is what causes it to have the enhanced signal over the other tissues. So here's the plot of the predicted contrast. And you also have to remember that with an MTC pulse, you have not only reduced the effective T1 values for the white matter, dramatically reduced it, maybe by a factor of 0.6. You've also reduced the effective water content as well, also by a factor of about 0.6. But you have not affected the CSF because it has no macromolecules in it. So CSF stays bright, the other two go dark. White matter goes dark faster than gray matter. And so if you put all these parameters together, representing what's happening, you can predict what you should see. So it's pretty flat here. So why am I not using, like, say, 15 degrees or even maybe 12 degrees? Well, the problem here is that CSF gets in the way because the lower the flip angle, the CSF is bright. So if I run this with a higher flip angle, you see what happens is then now the locus ceruleus relative to the CSF is getting brighter and brighter and brighter. But I don't care about that. That's not really what I'm after. What I'm after is the locus ceruleus relative to the surrounding white matter. So here I can use almost any flip angle, 16, 18, 20. It doesn't really make much of a difference. I can just choose that value so that I have good contrast. And I want to point out this to you. If you make this too high, the effective flip angle on a 3D sequence will get lower at the edge of the slab. So even though I ran this with 18, if you ask me what flip angle would I recommend, I'd recommend 20 degrees. Simply because if you started losing your flip angle as you went to the edges a little bit and you didn't set this up properly. So you can see where the center of this image is just a little bit above the top of the fourth ventricle when you do this. So that's if you want to collect the iron content. If you only wanted to do neuromelanin, you could even cut the number of slices down, but you will also, by doing that, cut your signal to noise down. So yes, you'll go faster, but you'll have less signal to noise. So those are all trade-offs for you when you're doing this. And then this is a plot here of 14, 16, 18, 20, and 22. And you can see that 18 and 20 are both pretty much the same on here. So in conclusion, you've seen that STAGE is really a very rapid, full brain coverage, 3D technique that can be used to help standardize imaging. Imaging the deep gray matter will provide us with iron content, neuromelanin content, and volumes, all of which are important biomarkers. Iron generally increases with age, so you have to remember to regress out the increased iron as a function of age before you call something abnormal in Parkinson's. Neuromelanin appears to significantly decrease in Parkinson's, but we have to remember that's a very general statement. It's going to depend on how long the person has had the Parkinson's. It's going to depend on their individual condition. Some may have larger neuromelanin loss than others. So it's not, a binary-like decision, right? And then the locus coeruleus neuromelanin can be imaged with sufficient resolution. And maybe the final comment here is with the right motion constraints. If you just put the patient in the magnet and you lightly put, these pads here like this, you will not see the LC 50% of the time, because all I need to do over 5 minutes is go like that. 1 millimeter motion, I have just blurred out the LC. So we use a very, actually we use like a foam cushion. Actually, I can even send you some of these because you know how you pack the Swarovski crystal, right? And those foam pads. Okay, so this is really a cute idea. I don't know why it took 40 years to find it, but you just cut a piece of that foam like this, wrap it around your head and drop your head back into the magnet, into the coil. And it automatically compresses your ears. I did this myself. I have never had a more comfortable MR scan in 40 years. We scanned me for half an hour, repeating the same scan again and again. I could take the 10th scan minus the first scan. There was no motion. And the image quality looks a lot better. I didn't bring it for you, but I did this to prove this to the people. I kind of just rotated my head tiny little bit during one of the scans. It's much noisier. It clearly has a little bit of artifact, not a lot, but it really destroys the LC. So the only way to do a good job on LC is you must make sure the head is well constrained. Okay, thank you very much.
Thank you very much. I'll take the opportunity for the first question, which relates to the locus coeruleus imaging. Is exactly, we have a lot of protocols that people are currently running, some of them taking 10 or 12 minutes. That factors into your final point about motion. But I think people might worry that they are measuring something different if they switch to this much faster protocol. Can you reassure them that what's actually generating the signal and whether there's any risk in changing to this protocol as opposed to other protocols that they might be using?
That's a good question. Let me first comment that they're running MTC as well. So there's either indirect or direct MTC. When you use multi-slice spin echo, it's an indirect MTC. When we run this scan, we apply an MTC pulse specifically that covers basically the whole volume. So they're both using similar concepts, and that is suppress the background. And white matter gets suppressed more than gray matter. So that tends to highlight the LC in both technologies. So I think there's little risk involved on that side. The other risk is we're not doing this with this high resolution. So many people do 0.4 by 0.4 in plane, which potentially can give you much sharper images, but they give you much noisier pictures. So I can tell you that in the neuromelanin imaging we do in the substantia nigra, for example, or in the LC, if you take one of our images, you can look at some of the papers that say, wow, this is really great. We created a template map. We took 30 patients and put them together, and here is our LC image. Those 30 patients look like one of my scans. So what does that tell you? So SNR is a very big issue from that point of view. And resolution is a big trade-off between them. If you were to run in the same scan time of 4.5 minutes, you probably would not have sufficient signal to noise to properly calculate the area of that LC anyways. So, I mean, these all just depend on the quality of the data. Are you using a 20-channel head coil versus a 32-channel head coil versus a 64-channel head coil? Most of the work I do is with 64 channels, but sometimes 32 channels. You have the best signal to noise at the edge of the brain with 64. 32 is still pretty good though. In the old days when all we had was 12 and 20, 32 looked great. But now there's a risk factor the other way. And that is, how much of your data is really good? How much data do you have to throw out? So you have a risk by not changing. Your risk is loss of information from patient to patient because you couldn't do a good job on the LC. Now, I have to tell you another story why that's important. So we scanned an individual many times before we had this special foam padding. And we didn't see the LC once. Next time we saw it on the left side. The next time we saw it on the right side. And the next time we saw it on both sides. What the heck? So how are you going to, in all these papers that have been published on the LC, how can I believe any of them? Somebody says, oh, the left side is more dominant or the right side is more dominant. Because it's so small, I'm not sure I can believe any of those past papers. So I think it's absolutely critical, however you do this, even if it's 10 minutes, if you have the right constraint, as I said, you can be quite stable for 10 minutes and probably do a very good job. The question is, are you learning anything new? So in our paper, I think that you saw, Roger, just published in Neuroimage, we also looked at the profiles associated with this, and we used the full width half maximum of the profiles to estimate the diameter. Now, it turns out there's a very interesting mathematics associated with that. If your resolution is high enough, the full width half maximum remains invariant. So it doesn't matter if I use 0.67 or 0.5 or 0.33, they'll all have the same full width half maximum, which is a measure of the diameter. So, 0.67 is only 3 pixels across the object. To do a good job measuring the cross-section of an object, you need 4 to 5 pixels across it. So clearly it's not going to do that, but it's still going to give you a decent estimate of full width half maximum. So you have a choice. You can do full width half maximum, full width 10th maximum, and you will get reasonably consistent results. And all the answers to those questions are in that paper. We also, in the same paper, did a high resolution scan. We only changed it from 0.67 to 0.5, so 0.5 by 0.5, and it's already much noisier. And basically we get the same quantitative results from this. So all that data is published, and that's kind of why we didn't want to run a 6-minute scan. We stuck to the 4-minute and 20-second scan. So 0.67 was a kind of our endpoint at that point.
There's one in the chat. I'm going to stop sharing so you can read it easily.
Sure. Thank you.
Go ahead, and then if you scroll up a little, he has a second question as well.
Oh,
Maybe give a little recap before.
sure. I can just read the question here. It says, our institution, it's from Joseph Ugorji. Our institution uses stage. And so in MS, with the T1 weighted enhanced image or the R2 star image, be the best assessor of irreversible myelin loss in a plaque? Or is there a better stage sequence or something better than R2 star? Okay, so I would answer that question first by reminding everybody that you can have demyelinating lesions that are just demyelinating. You can have inflammatory lesions, and you can have demyelinating inflammatory lesions. And one of the goals is to be able to separate these. So, in one of the first papers we published on this with Jim Garburn about 10 years ago was that we could find things on QSM and phase. We could find lesions that you couldn't even see on FLAIR. That was about 10 to 20% of new lesions could be seen. So what are those lesions? Those are demyelinating lesions. Now, whether or not, it's irreversible myelin loss, I can't say. Then if you use the water content example that I just showed you here, and there's no indication of changes on susceptibility, then that's a purely inflammatory lesion. The water content will help tell you basically how chronic that is and how much atrophy is taking place locally. So that's the advantage of having the water content, and stage processing will give you the water content. My processing is similar to stage. I just call it spirit processing, but we do things differently. Our T1 optimized imaging is totally different than T1 weighted enhancement. And then there's the combination of the two. So there's another paper we published you might want to look at where we did almost everything under the sun to study MS. Everything from PSIR to MTC to myelin water fraction to DTI. And we then mapped all these out and compared them to water content. And basically, everything correlates with water content except the QSM. So if you really are looking at chronic lesions, DTI doesn't add anything to the story. Neither does myelin water fraction, neither does the MTC, MTR. However, myelin water fraction correlates with QSM. So to answer your question, if you have a shift of susceptibility of at least 50 ppb, then you basically demyelinated that whole territory. We find in many cases the demyelation is only 10, 20, 30, 40 ppb, so maybe not fully demyelinated. So you might take a look at some of those references that I just mentioned. And one of the co-authors on those papers with me is Professor Sagar Buch, spelled B-U-C-H. Oh, that's a very good question. So we have a separate software that we're using right now to detect the deep gray matter. And then, of course, once you've detected it, to do the volumetric calculation and automatically do the iron calculation by overlaying those boundaries back onto the QSM image. We are working to try to integrate that into a full volumetrics. So, if you're interested, please feel free to contact me, maybe through Roger if you want. And we're doing this with a group in Canada called VoxelWise. So maybe that's something we could share, but that is, using the NVIDIA, I think the new NVIDIA cards. So you're going to need an AI dedicated station, which you probably have here at UX. You must have that at UCLA already. And, even then it takes about probably 10 minutes a case to process that data. But, that's one way to try to do this. We also have some early software that we developed that we might be able to share with you if you would like to try this. That's a precursor that was fed into the AI. It's actually an algorithmic approach to solve the problem, which works pretty well, actually. And it can be run standalone. Let's see if that answered his question. Yes, I think so.
I'll ask one final question having to do with adoption and stage. I can see where the scanner vendors might not like the added efficiency because they could sell fewer scanners. But why aren't radiologists falling all over themselves to implement this, given how the throughput is so much better?
Well, that question is probably like iron increases as a function of age. Resistance increases as a function of age. So, the older radiologists, they don't want to learn anything new. The younger radiologists are the one publishing all the papers, right? So you can see this linear change in attitude. To get something new adopted, it's a big deal. I mean, even MRI angiography, which we all use today, right? I think that took us about 7 years to get that approved to have its own DRG code. It was a very big deal to do that. SWI, I think, took at least 5 years to get accepted and adopted. It takes time to convince people that they can really rely on this. So, it's great technology, but we need probably like a clinical trial where we have, 5 or 10 sites doing this. Even though I've done it on 500 cases and I'm reasonably confident, I think we need enough sites to do it that you would then attract a conversion from conventional to this new technology.
Something to look forward to.
Yeah.
All right. Well, let's all thank Dr. Haacke for